Hello, everybody. I'm really excited to be here with you guys. Good morning, good evening, wherever you are. My name is Mina Ostovari. I'm a senior clinical researcher in Christiana Care Health System in Delaware. And today we're going to talk about application of analytics in healthcare. So before we start, I just want to say that I have no conflict of interest to declare, and my views or opinions, they don't necessarily represent the position of Christiana Care. All right, so I want to start with a brief introduction to myself so you would know me better and the path that I took that now I landed in healthcare research. I started my PhD at Purdue University, and at the beginning I was working in human factors, so I really didn't know much about healthcare. But along the way, I had a couple of experiences that I really became interested in how engineers can transform healthcare. So the first one was in AbbVie, which is a pharmaceutical in Chicago. It's a great environment. They do different research specifically focused on chronic conditions. If you guys don't know about them, check them out. They have great opportunities for people who work on data analytics. So when I was working there, I was working on projects about design of medical devices for patients with diabetes. And it was really there that I saw how we can transform patients' lives with what we know. A couple of months after, I had a position as a graduate research assistant in the Reagan Street Center for Healthcare Engineering, or in short, it would be ARCHE. So if you don't know them, they're in Indiana. They have their main institute in Indianapolis. They do great research in health services research area as well. Recommend checking them out. They also have positions for students who work in this area. And it was really there that I learned about different types of data sets, claims data, biometrics, and how to apply like machine learning and social network analysis, which is what I do on this data to provide insight. So it was there that I developed my dissertation, which was about the impact of healthcare provider collaboration on outcomes for patients with diabetes. And since graduation, I've been working as a senior clinical researcher in Christiana Care Health System in Delaware. All right, so that's me. I will provide my contact information at the end. So if you guys want to get in touch and ask any question about, my experiences, you can do that. So let's talk about the good stuff, analytics. We hear this word a lot, right? Especially as after COVID had started, we hear analytics, informatics, data science, they're buzzwords of our era. And well, there are different definitions and they're pretty much similar to each other, but basically analytics is about systematic analysis of data in hand. So Gartner, which is a research firm, they presented this model to define different types of analytics and how different or similar they can be. Now, you guys might be already familiar with this. Well, basically, we start all the way from descriptive analytics, which is something that if you work with data, we all do this. So it's looking into the data, what kind of information we can get about the data. It's for providing information from the raw data. And then there is descriptive diagnostic analytics, which in diagnostic analytics, many tools that we learn in engineering and in statistics as well, it's helpful in diagnostic analytics. So for example, in industrial engineering, we learned a fishbone diagram, which is like literally a fishbone if you haven't seen it, and it identifies different factors that impact an event. And believe it or not, many projects in healthcare that I know of, or even in other businesses, they benefit a lot from descriptive analytics and diagnostic analytics. So don't undermine this. Despite their simple approaches. And then we have predictive analytics, which is a little bit more complicated. It's about what may happen in the future, not what will happen, but what may happen. And then we have prescriptive analytics, which is if something happens in the future, what are we going to do about that? So these two are more complicated. They need more expertise, more tools, but they're very helpful to provide tools for businesses or healthcare. Now, when we talk about healthcare specifically, healthcare analytics is pretty new in the past couple of years. People in healthcare are trying to really make use of data. There is lots of data that's collected in healthcare, like any other organization, because we have internet, we have different platforms that we collect the data for patients. So we are looking for ways to see if we can use that data to help healthcare. Now, a long time ago in 2005, basically the Institute of Medicine wanted to see how we can systematically analyze healthcare. So they started this project with National Academy of Engineering, in which they started defining healthcare systematically. So this is basically a model that you can see. It's a framework. It's a nested model that describes healthcare. So in this model, as you can see, we have patients in the middle. So we always talk about patient-centered care, right? Everything goes around the patients. And then we have the care team, the next level, basically whoever provides care directly to patients. It can be maybe the first thing that comes to our mind is nurses or physicians, but we can't neglect other people. Anybody in the hospital who cares for the patients, you know, patient escort, people who take care of the patient inside the room, people who bring food, they're all caregivers. And also the family, because the role of family has been neglected for so long, but they're also important. And then the next layer is organization. It can be hospitals, a big health system, or it can be small clinics. And they're also very important as well. And finally, we have the environment, which is basically the most complicated one. There's so many players in this environment. There is government that, you know, they have all rules and regulations that apply to health systems. There are insurance companies play a big role, especially in costs. Then there are research organization, and when they do any kind of research and provide perspective, that would impact the regulations. There are donors who donate money. So as you can see, there are so many different players who are involved. And that's why this model that may seem simple, it's very important, because we got to understand the complexities and the dynamics that exist in healthcare and make it really complex. And it wouldn't be as simple to just develop a predictive model and say this is going to happen, because there are lots of things that are going to play a role, and we have to consider them. So as we can see, because of the complexities of the healthcare, and also because US is a very large country with close to 330 million people, there are lots of challenges that exist in US healthcare system. And they were actually highlighted during the COVID era. Unfortunately, we saw people who were from underserved population, they were hit harder by COVID. We saw people who had underlying conditions like diabetes, hypertension. They had a higher rate of complications compared to other people. Opioid crisis, there is research going on that shows that people who are suffering from opioid, because of COVID, their care has been impacted. And, you know, these are not going to stop. Opioid crisis still exists, and we are hit by COVID. So all these things were brought to light by the analysis of data. And that's because of that healthcare analytics is really important to provide insight to healthcare organizations, to government, to health policymakers. All right, so what type of data do we have available in healthcare? When we think about health data, the first thing that comes to our mind is data that's collected by hospitals, by clinics, healthcare organizations in general, and that's electronic health records, or EHR. You might be familiar with that if you work on health-related projects. So some people may say EMR, or electronic medical records. That's not correct, because EMR is much more limited. It belongs to one practice. It cannot be shared. EHR is basically a comprehensive history of patients, so everything that has happened to patient, all the medication, all the hospitalization, all the visits, everything is there. Depending on the platform that's been used for collecting these data sets, because there are different platforms, you may be able to add even more. Like, for example, if patient use wearable devices like watches, and the data is collected, it can go to EHR. So it's really good, not just because you can collect so much data, but also because it's really important for coordination and communication of healthcare providers who are affiliated in one health system. Now, If you're not in a health system, or if you're not working in a research center affiliated with a health system, it might be a little bit more difficult to get access to EHR because of privacy concerns. But you may be able to purchase claims data. Now, claims data is collected by insurance companies for billing purposes specifically. And the structure, from my point of view as a researcher, because I don't clean the data as much, I do a little bit, but not too much. The structure to me is kind of similar to EHR. It's limited in terms of diagnosis. For example, in EHR, you can see up to 66 diagnoses for each patient. In claims, it's maybe top 12. You can still see all the visits to hospitals and outpatient visits to, for example, a provider office, but it's not as comprehensive. It's still pretty good. You have to purchase this data set. So usually there are companies who purchase these data sets from insurance companies, and then they clean them up, then they sell it to research centers. They're pretty expensive. For example, I have a project that I need to look at everybody's data in Delaware. And Delaware Health Information Network is the organization that manages this claim data. For one pool, it's $24,000. So you can see it's expensive, but if you apply for grants, you can purchase those data sets. The other data sets that's really important is census data. Now, if in recent years especially, we are really thinking about disparities in healthcare, underserved population. So census data is important because it provides information about socio-demographic characteristics of population, for example, their education level, their income, and you can see some data online. You cannot see the details. To get like the whole data sets, you have to be in an organization that's approved to get access to that. There are some hoops that we have to jump in, but it's possible. And the census data is transformed to make sure it's completely de-identified, and you basically cannot detect anybody. But it's very helpful for disparity research. And then there are data sets that are online and public and available to everybody, which is great, because if you're an independent researcher, or if you have never worked with health data, you can look up these data sets and you can get a sense of what they represent. So first, there is patient or disease registries. They're typically focusing on chronic conditions, and basically you can see the trajectory of a patient, their outcome, a big group of patients, completely de-identified data, but it's pretty good to define different research projects and get a sense of patient outcomes for specific conditions. Because it's publicly online and available, you don't need IRB. So another great thing about these data sets. And so is health survey, which are specifically designed and collected for research purposes. So people who collect this type of data, depending on what organization they belong to, they have different procedures, but like they go to a region and they collect data from like a large population. So it's pretty good for research. And I really recommend you check them out if you've never worked with health data, to see if you can define projects or what kind of variables is there. All right, so these are the data sets that are available in healthcare, and we can use people who knew how to analyze the data. Now, I want to go to an example of projects, but before that, I want to ask if anybody has any questions you can ask about what we talked about till now. And I can't see the chat, but if somebody can tell me. Is there any question? I mean, can you tell me if there is any question?
I have a question. You talk about some data sets and comparison of them. Mm-hmm. So for our students, do you think if they get to an industry jobs, in terms of doing healthcare analytics, which kind of data set they might work the most?
Great question. So really depending on where they end up, because I work in a hospital now. So the main type of data I work with is EHR. But if I develop a project that really requires a bigger data set and I want to look at a bigger population, I can get access to claims too, although that would need applying for grants. Census data is also something that we use a lot. So, but it's more for public health type of projects, so not population health. So it depends on where they go and what they do. They may not necessarily work too much with patient registries or health surveys. Now, if they go to a research institute like Reagan Institute that I was before, because it was not affiliated with hospital, we could purchase claims data, but we could not get EHR. So to get an EHR data, if you're not affiliated with the health system, or if you're not part of a health system, you have to sign a data use agreement. And procedure is not that simple. It gets a little complicated. So basically that would be the data set they can work with.
Thank you.
Sure. Any other question, comments? No? All right. Okay, so I wanted to talk about a different project, but then I thought this project is something that we all can relate to because it's related to COVID. And we may be somehow tired of hearing about COVID, but it's still with us. So this project is about contact tracing. And at this point, maybe you guys all know what contact tracing is, but let's revisit this topic. So contact tracing is basically a public health service that usually it's done by health departments, which are a small organization, or they can be big depending on the size of the state. And they provide different types of health services. One of them is contact tracing. So when there is an outbreak in the community of an infectious disease, or in our case, pandemic now, because it's much bigger, contact tracers are people who go identify the case, they call them and they ask them about who they were in close contact with. Then they call the contacts without telling them who the case was, and basically provide them the steps, what they have to do. If they have to go to quarantine, they have to get tested. So the procedure is different depending on the condition. Now, we're talking about COVID now, but contact tracing is not something that's only related to COVID, because we have to remember that years ago we had SARS and we had MERS, which basically were from viruses similar to COVID, the same family of coronaviruses. And we had Zika virus as well. Now, they are under control now, but you never know what's going to happen. And basically, all health departments are always ready for that. Same thing in the hospitals. In each hospital, there is an infectious control team that if something happens, if there is an outbreak of any kind, they can, start working on that, and they can trace the cases and contacts. So it's really, really important. Now, in terms of healthcare workers in the hospital, when there is a disease like COVID that can rapidly, spread, contact tracing becomes difficult. It really becomes cumbersome because, there are not many people who can work on a specific thing. It takes a lot of time. So this project was brought to me by a physician, and he wanted to see if there is any way to facilitate these efforts. Now, this is before Google and Apple came together to basically design this application programming interface. It's not an app. It's basically what they designed. It's an API. And I'm not a computer scientist, so I just know how it works to some extent. But they basically came together. I don't remember the exact timeline. I just know it was before our project, which we started in March. So basically they designed this and they provided it to states to design their own app. Now, I'm not getting into the details of that procedure, but we can discuss it later, certainly, and the problems that it had. But as far as I know, there are not many states who developed that app and are using it. But, there are issues with contact tracing, specifically if you are thinking about identifying the location of people. Now, in other countries, they have done it, but they have their own system. In the US, we cannot get access to the location of people using their phone. It's not accepted. And there are privacy concerns that we have to consider. So because of that, this person came to me and said, well, social network analysis, can we apply that to this topic? And I said yes, because when you apply social network analysis in epidemiology, the network that you develop will be a contact network. Now, for those of you who might not be familiar with social network analysis, it's something very similar to graph theory. Basically, it uses the measures from graph theory to model and quantify relationships between people. So that's why we call it social network analysis. It kind of reminds of Facebook and Twitter, similar idea. But, you know, we find a way to connect people. And when we are using this approach in epidemiology, it becomes a contact network. And it's really important that we identify people who have a great impact on the spread of disease. So we want to use measures of social network analysis to identify those people. So we were thinking about the approach, and this is where I want to talk about challenges, because, you know, well, I think I work in healthcare, so I have access to all data sets that I want, but in reality, it doesn't happen, especially when it's a matter like COVID, which is very important, and some data are confidential. So when we thought about data, well, all physicians, they have, and nurses, some nurses as well, they have their phones, and their phones, basically, the location is tracked through a company, like any other data in their phone, that's their work phone. And we thought, can we get access to that data set, which we were told no. And there's also physician or care provider badges. Everybody has a badge. They go around in hospital, and there are devices that are supposed to read those badges. Now, we also asked if we could access to that, but we were told no. So even if we didn't want to share any data, we were not allowed to use that data sets, which is understandable, you know, privacy concern. They don't want you to know, whoever you are, what their location was. So the only data set that we had available was EHR. Now, I explained it a little bit. In EHR, we have so much information, so much data about patients, but it's all about patient. So we can see where the patient went, what unit, and we can see patient's provider, but we cannot really see the location of the provider. So that's one of the challenges of this project. And if any of you guys have any insight about that, I would love to hear. So we really wanted to accurately define a population, and we thought, okay, what can our population be? Because we think about all the patients with COVID, but the truth is many patients come on a daily basis to the hospital. Now, not all of them came for COVID. So patients who came to the hospital for COVID, there were specific protocols for them. So there were design protocol that what should be done for this patient. There was specific PPE. Now, something to keep in mind is that this is for a couple of months ago. So protocols and PPE usage, protocol, personal protection equipment usage, they have evolved over time. So we're talking about then. And but anyway, the procedure for these patients who came to hospital with known cases of COVID was different. And then there were patients who would come to the hospital, they didn't have symptoms. We know that COVID can be asymptomatic, or maybe they got it, you know, while they were coming to the hospital. We don't know the source, but these patients did not show any symptoms. So they didn't go to COVID units immediately. They went to other units, but maybe after a couple of days, they showed symptoms, or maybe after a couple of hours. So they were tested, and when the test came back positive, there would be an event in the EHR that showed that this patient would go to isolation. So we focused on these patients who did not go to basically isolation at the beginning, but after they were admitted, and their providers as well. Now, the approach that we had was social network analysis to design this network, and also predictive modeling to basically predict the impact of the structure characteristics of the network and the provider characteristics in the network on their exposure rate. Now, I'm gonna share the social network analysis finding with you guys, and cannot really specifically share the predictive modeling part. So it is a little too much text here. I don't expect you to read this. Basically, this is like 1/4 of explanation that our data analyst he sent to me, and we discussed this, how to define our data sets. So this was something that we did for a 14 days period. Basically, we designed a model, and then it could be applied to other periods. The reason for that was it was a period of time that we had a surge in the number of patients, so like a very quick increase. And also, we know that with COVID, it takes 14 days. During this 14 days, the patient, whoever the patient is infectious and can transmit the virus to other people. So we focus on 14 days specific timeline in a couple of months ago, not mentioning specific dates, but during this 14 days, we looked at all the patients who came to the hospital and they went to isolation after the admission, and then their providers, okay? So we looked at their providers, and also we wanted to identify who else worked with these providers. Now I'm gonna explain that later as well. Something to mention here is that different things are done for patients, and we really wanted to focus on all the providers who did some sort of procedure to the patients that needed close contact. So the provider had to be inside the room with the patients. So as you can see, this is just a snapshot of a table from the EHR. In the EHR, everything is documented for patients, not just for billing purposes, but for legal things as well, because you want to document every group of patients. So we divided three groups. For example, like one was administrative, one was clinicians. And then for each group, we looked at their clinical events that showed what they did for the patients. And if in one group, everything that they did was mostly administrative work, we removed them because administrative work doesn't need the provider to be in the room with patients. So basically, administrative staff were removed, and they're still considered caregivers. So it's not like we didn't understand that from the beginning, but we call everybody, all the healthcare provider, caregiver who did something for patients. So we removed everybody who just did administrative work. We kept everybody else who did some sort of care for patients that needed close contacts. Now, we want to define our network, and here's when it gets a little tricky, because as I mentioned, we don't have healthcare provider unit or healthcare provider location. So this is based on an approach in 2011, a paper by Barnett from Harvard Medical School that I can send it to you guys if you're interested. Basically what they showed was, if from the health data, we can see healthcare providers who share patients, we can consider some sort of working relationship between these healthcare providers. Now, it can be that they have a formal relationship. For example, they work, they do referrals, like primary care referred to a specialist, or it can be they just have chats about the patient. For example, in a hospital, in the break room, like they're talking about patient, which actually happens a lot, especially in a hospital. Now, in a hospital, the probability that these providers who provide care to the same patients actually have to work together and may have contacts is higher, because it's one system. And especially if we are focusing on a specific group of patients, the probability goes higher because, there are specific providers who are assigned to these patients. So if they provide care to the same patient, then we can consider that as some sort of relationship. So this is how I define our network. The nodes represented healthcare provider, and they were connected by an edge if they share patients. Now, the patient sharing relationship, the number of patients would be the edge weight. So that would show how many patients were shared between healthcare providers. Now, again, understand that this is not particularly showing the locations, and if you guys have other suggestion, I would love to hear what other approach we could have used. But this is how basically we define our network. So I want to share the network characteristics with you guys. This is the organic network. So this is not that pretty. I used R and I didn't apply any structure to the network, but I just wanted to see how the network would look like. you can see that there are kind of hubs in the network, bigger group of nodes that are more densely connected. So that's interesting as well. In this network, we had like 3,000 healthcare providers who provided care to patients with COVID. The edges represent patient-sharing relations between healthcare providers. So we had 55,000 edges. The edge weight, again, is a number of shared patients. The average edge weight was 1.48. So we can consider like two patients shared between healthcare providers overall. The network was undirected, so we didn't consider directions in the network because we couldn't see who would refer to somebody else. We couldn't see that, but it's weighted. And also it was connected network. So meaning everybody was connected to each other, either directly or indirectly. All right, one of the measures that's really important in social network analysis, it's one of the micro measures basically to describe each node, is called centrality measures. So centrality measures are used to identify the important nodes in the network. And important means different things to different people. So in our case, important would be somebody who would impact the spread of a disease. There are different measures that can be used. The measure that we used here was degree, betweenness, and closeness. Now, degree is a direct number of connection one node has. Betweenness is control over the flow. It can be flow of information or it can be spread of the disease. So to explain it, let's look at this small network that we have. We have this respiratory staff in the middle, and we have a nurse in the left, and we have 3 other providers in the right. So imagine that nurse F, unfortunately, has COVID, gives it to respiratory staff, and then if we remove respiratory staff, then these 3 other people would not get COVID. So this respiratory staff in the middle, it has a high betweenness because it has control over the spread of the disease in this network more than other ones. And then there's closeness centrality, which is basically can be applied on connected network, not disconnected. And it's basically the access of one node to other nodes in the network. So the closer than one node is, the easier that would be to spread like disease or information. And the calculation of these can get a little complicated for weighted networks, but we can use, of course, softwares. We can use R or Python to do that for you. So we applied these centrality measures on a network, and usually when we have nodes that are central, all centrality measures would show them. So the nodes that were central based on all these 3 measures were respiratory staff, ED nurse, and patient care technicians, which is really interesting because let's think about that. Even without knowing if these were people who got infected or these were people who infected other people, respiratory staff, people who do lots of respiratory procedure on the patient. So they have to be really close to the patient and they can really be exposed to the virus. ED nurse, they work in the emergency department. So they receive the patient, and if the patient doesn't have any symptoms and they're not a COVID patient, the nurse could be exposed, as they don't have the PPE of COVID. Then the patient care technicians, they do a lot of work physically for the patient. They really take care of patients, and maybe their role is not, they're kind of, to me, like invisible caregivers because they're not considered as much compared to maybe nurses or physicians. So one more thing that we did was we applied a community detection algorithm to this network. Basically, it's like clustering analysis of big data, but for networks. We applied that to identify a group of nodes that were more densely connected. And these are basically groups that we have to pay attention to, because if there's a disease spread, we can look at this and say, okay, if this is the smaller dense group, then we have to really pay attention to who is in that group, what procedure can we do for these people. So when we applied the algorithm, which we used the Louvain method, we saw 6 different hubs or communities on the network. Now, there are different community detection algorithm that you can use. It can be disjoint, overlapping. That might be another discussion, but basically Louvain is a disjoint algorithm that identifies nodes with a higher density of edges inside them compared to the rest of the network. So if you look at the network, and this is the organic network that I showed you before, the original structure of the network, you can basically see the 6 community even without Louvain telling us, because look at the big ones, like in the we can see here there's a big one, and then there's one here, and then one here, we have one in the middle, and these 2 here. So we can basically see the communities if we look at the data. That's why looking at the data is so important. Looking at your network is so important, because you can actually see the patterns. Now, the community size was all the way from small community 51 to 1,000. So different communities of nodes, and we applied centrality measures to each of these community as well, because let's think about that. These are like subgraph of the network, so we can apply the centrality measures to each of these as well. And it was really interesting because we saw the same pattern. We saw that, and equal number of communities as well. We saw that the respiratory staff was central, ED nurse was central, patient care practitioner was central as well in 2 communities. So it was an interesting thing to learn about our network, that they're not just central in the overall network, but also in their communities as well. So that's the extent that I can share about this project, because like the information about who got exposed and who didn't get exposed, that's a little confidential and I can't share. But I just wanted to show you guys that even if you just, to this extent, even if you just provide some information, it's really helpful for healthcare providers. It's really helpful for whoever is planning, you know, resources in the hospital, or how to design procedures. So don't underestimate the impact that you can make, even with projects that may not seem too complicated or too fancy. All right, with that, I want to close the presentation. Thank you so much for accompanying me during this presentation. I hope it was helpful. If you think that you need more help, if you think you want to reach out with your question, please feel free. This is my personal email. I'm going to check that often. And this is also my Twitter handle. I'd be happy to connect with you guys and answer your questions in the future. Thank you.
Thank you very much. Very interesting talk. Before the students might come up any questions, I have a question. So, as you know, there's usually university have a big break right now. So and some of my students are interested to get to the job market next semester, start applying. So what you recommend for them to focus in their toolset arsenal to be more attractive for the institutions that are in healthcare analytics? So let's say next semester they want to be in job market, what should they focus or improve in their resume to be to have more chance to join some institutions like what you mentioned so far?
Right, it's a good question, thank you. So it really depends on where you go, what type of analysis you're going to do. Because if you're going as a data scientist, what they expect from you is going to be different if you're going as a researcher. If you're going as a data scientist, for example, they really want you to be very fluent in one type of programming. So it really depends on what they use. Typically, I've seen Python is very popular and useful in healthcare. So if that's something that you know, great. If you don't and you know R, that's good too. But you really need to be good in programming in one of those, like either R or Python or SQL. So programming is something that you should know when working with health data. If you want to be a researcher and doing research, it's a different story a little bit, because maybe your technical skills matters, but not maybe as much as your ability to really start a project, lead the project to the end, and having good communication skills matters. So it's more about like leadership and making sure that you can get the resources that you need for that project. So really depending on what they want to do and what they want to apply to their job.
Thank you very much.
I maybe can stop sharing because I can't see the chat.
I'm checking for you. Yeah, as I said, many of the students can't watch it synchronously, so probably they watch our video later, and they might, in case of questions, they might reach you through the email. But I mean,
Sure.
we have about 20 students now, but there are much more, about the 50, 60 students. So
Right.
hopefully
Yeah, they can feel free to connect with me, even LinkedIn as well. And I typically get back to questions maybe in 1 or 2 days, but I would be happy to answer any other questions if they have. And also about strategies to maybe improve their resume or application. It's a little hard. It's a little hard now. I'm going to tell you that because of COVID, but we will see more positions open up maybe in January. Maybe now we don't see many, but in 1 or 2 months, I'm pretty sure that they're going to open up.
Thank you very much. Very interesting talk. I appreciate it. It seems very useful for our students, and I totally appreciate your time.
Thank you so much.
Thank you.
Bye.
Bye. Have a good day.